Hello everyone, this is Medical Gateway and we are studying chapter number 33 of Guyton, and in this part we are going to study regarding anemias. So morphologically, anemias are divided into three types. So what exactly is anemia? Anemia is decreased in red blood cell mass or decrease in hemoglobin concentration. So either decrease in red cell mass or decrease in high hemoglobin concentration is known as anemia. So morphologically, anemia is divided into three types. One is microcytic anemia, then we have normocytic anemia, and then we have macrocytic anemia. So the normal size of the red blood cell is 80 to 100. Okay, so MCV is 80 to 100. So all the anemias having the normal size are known as normocytic anemias. So if the size of the red blood cell is less than 80, okay, so if the MCV, mean corpuscular volume of RBC, is less than 80, then it is said to be microcytic anemia. And if the size of the RBC is greater than 100, the MCV is greater than 100, then it is known as macrocytic anemia. So what are the different types of microcytic anemia? So microcytic anemia include iron deficiency anemia, anemia of chronic disease, thalassemia, and sideroblastic anemias. Okay, when you have CBC report, there you have hemoglobin. So if the hemoglobin is lower than normal, then you go to the MCV and you see what is the MCV of the red blood cell. So now if the MCV is less than 80, then it means it is microcytic anemia, and then it means the causes are these four. Either the anemia is due to iron deficiency anemia, or due to the chronic disease, or due to thalassemia, or it is because of sideroblastic anemia. Now, iron deficiency anemia, as you all know, the hemoglobin consists of iron. If there is iron deficiency, then the proper hemoglobin cannot be formed, which results into iron deficiency anemia. Then we have anemia of chronic disease. Any chronic disease can result into anemia, and that anemia is also a microcytic anemia. Okay, so anemia of chronic disease. Then we have thalassemia. As discussed previously, thalassemia can be alpha thalassemia or beta thalassemia. In alpha thalassemia, there are some genetic defects with reference to alpha chain of hemoglobin, whereas in beta thalassemia, there is a genetic disorder with reference to the beta chains of hemoglobin, and in them the normal hemoglobin is not produced. So the anemia because of thalassemia is also a microcytic anemia. Then we have sideroblastic anemia. In sideroblastic anemia, basically there is defect of iron addition to the hemoglobin. Now what happens in here is that the iron starts to accumulate in the mitochondria, and those mitochondria filled with iron will accumulate around the nucleus in the RBCs. So normally the RBCs does not have nucleus, but in sideroblast anemia there are blasts. So there is the RBC is nucleated, and it has iron-filled mitochondria surrounding the nucleus in the form of sideroblasts. Sorry. Then we have normocytic anemia. In the normocytic anemia, now first discuss the macrocytic anemia. In the macrocytic anemia, we have vitamin B12 deficiency, we have folic acid deficiency, then we have liver disease, and we have drugs. So we have discussed regarding the vitamin B12 and folic acid deficiency. Basically, in these deficiencies, there is defect in the maturation of the red blood cells. Okay, so when the red blood cells are not matured, there is nucleocytoplasmic asynchrony, which results into relatively larger size of the red blood cells. A smaller sized nucleus with the larger sized cytoplasm, which is giving a macrocytic picture of the red blood cells, where the mean corpuscular volume is greater than 100. Then we have liver disease. Now, in liver disease, there is also deficiency. Liver disease might cause the deficiency of vitamin B12 and folic acid. So, liver disease can also lead to macrocytic anemia. Then we have some drugs like methotrexate and many others which can cause anemia, and the picture is macrocytic in this case. Okay, then we have normocytic anemias. The normocytic anemias can be because of production defect, and it can be because of hemolysis. So first, let's discuss the production defect. Now, if the RBCs are not being produced, for instance, in the case of aplastic anemia, now aplastic or aplasia means that the bone marrow is not producing the red blood cells. So that is known as aplastic anemia. Okay, then we have renal disease. In renal disease, the RBCs will not be produced in the normal quantity because the kidneys have to produce the erythropoietin, and erythropoietin then produces the facilitates the process of erythropoiesis. So, in the case of renal disease, because of the low erythropoietin levels, there is anemia, and that anemia is normocytic in picture with the MCV 8200. Then we also have malignancies. In the malignancies, there is also some production defect of RBCs from the bone marrow. Okay, now, so normocytic have one is production defect, and the other one is hemolysis. Hemolysis also causes normocytic anemias. Now, hemolysis include number one, hereditary spherocytosis. Now, as you all know that the RBCs are normally biconcave in shape, so in hereditary spherocytosis, the RBCs are converted into a spherical shaped RBC. RBCs lose their membrane and they're converted into a spherical shaped RBC. Now, this spherical shaped RBC, whenever it is passing through any small pore, this RBC will be ruptured, causing anemia. So when the RBC is ruptured, the RBC is hemolyzed. So this is hemolysis, and this will give a normocytic picture. Then we have sickle cell anemia. As we have discussed previously, the sickle cell anemia, there are sickle-shaped RBCs which are produced because of the exposure of hemoglobin S to the low oxygen. So now these previously normal hemoglobin will be converted into crystals, and those crystals will convert the RBC into a sickle cell shaped RBC. Now that sickle cell shaped RBC will get stuck in the capillaries, and then they will be hemolyzed, giving rise to anemia. Okay, then we have erythroblastosis fetalis. Now we'll discuss erythroblastosis fetalis just a few chapters after this. In erythroblastosis fetalis, there is hemolysis in baby. We'll discuss in detail afterwards. Then we have G6PD deficiency. Now, whenever there is G6PD deficiency, this also leads to anemia. Now, G6PD protects the red blood cells from the oxidative stress. Now, whenever there is G6PD deficiency, the red blood cells are more prone to hemolysis, giving rise to normocytic anemia. Then we have paroxysmal nocturnal hemoglobinuria. Now, hemoglobinuria. Urea is from the urine and hemoglobin is hemoglobin. So, if hemoglobin starts appearing in the urine, that is hemoglobinuria. So, nocturnal hemoglobinuria means, in basically paroxysmal nocturnal hemoglobinuria, there is hemolysis, and that hemolysis takes place at night. And when the person wakes up, so the first urination of the day gives a picture of hemoglobinuria, the hemoglobin in the urine. Then we have autoimmune hemolytic anemia. Now, in autoimmune hemolytic anemia, the hemolysis of the red blood cells is because of the autoantibodies, which are causing the RBCs to rupture. Okay. So these are briefly the morphological classification of anemias. The patient comes to you with, for instance, the patient is fatigued. You go for a CBC report, then in that you see the hemoglobin of the patient is low. Then you will immediately see the MCV of the patient. So now you have to see whether the MCV is normal or MCV is low or MCV is high. Then from that, and with the combination of history and few detailed tests, we can just rule out that finally the cause of the anemia. Okay, so this is morphological classification. Now let's discuss a few other points regarding the anemia. So now we have blood loss anemia. For instance, if someone suffers from a car accident and then there is rapid hemorrhage and he goes to the hospital, then what happens, how the body responds to it? The body replaces the lost blood with the fluids immediately in 1 to 3 days. Now, if someone has lost 1 liter of blood, then in order to maintain the blood pressure, the body will replace that blood with the fluids in the next 1 to 3 days. Now, this will cause hemodilution. This will cause dilution of the RBCs in the blood. Now, this hemodilution will lead to anemia, that is relatively decreased mass of RBCs or decreased concentration of hemoglobin. Now, but this anemia will return to normal in 3 to 6 weeks. Because the body will start to produce more erythropoietin and will start to generate more RBCs to compensate the loss. So this is in the case of acute loss. Now, if there is chronic blood loss, the blood loss is continuing from one part or another. For instance, there are some GI cancers or continuously bleeding ulcers or hemorrhoids which continuously keep bleeding. In that case, the iron is not absorbed as rapidly as the blood is being lost. So now the body tries to increase the RBC production, but the speed of the loss of the blood is greater than the speed of the absorption of the iron. So what happens is that, but the body will keep on trying to increase the RBC production. Now, what will happen that body will start producing smaller RBCs than the normal, with less hemoglobin present in them. Okay, so now in the chronic blood loss, the body cannot compensate by the production of the RBCs. There is less iron as compared to the blood lost, but the body is pushing the bone marrow to produce more RBCs. The bone marrow will start producing RBCs, but they will be RBCs of smaller size than the normal, and they will have less hemoglobin as compared to the normal RBCs. Then we have hereditary spherocytosis. As we have discussed earlier, that RBCs lack normal loose bag-like membrane in hereditary spherocytosis. The shape becomes spherical instead of biconcave, which makes them very difficult to pass through the red splenic pulp or squeeze through the red splenic pulp, and because of that they get ruptured in the spleen and then they're eaten by the macrophages there, resulting into anemia. And finally, we have the aplastic anemia. In aplastic anemia, there is basically damage to the stem cells from which the red blood cells are to be produced. Now, if the stem cells are damaged, then the bone marrow cannot produce the red blood cells. Now, what are the causes of damage of stem cells? Now, conditions like SLE, systemic lupus erythematosus, or radiations or chemotherapy in the case of different cancers can result into aplasia. Even the insecticides used to kill insects in the farming, and even the substances like benzene, can cause damage to stem cells. So SLE, radiation, chemotherapy, insecticides, and benzene can damage stem cells, leading to aplastic anemia. So what is the treatment of aplastic anemia? Number one is we should stop the insult which is causing the aplastic anemia. And then we can give blood transfusions to counter the decrease in the production. Okay. Now, if we don't have any cause or we don't know the cause, then that is known as idiopathic aplastic anemia. Okay, so if the cause is unknown, then that is known as idiopathic aplastic anemia. So this is it. We have discussed basically the morphological classification of anemias and few other points regarding the anemias. Now we are going to discuss the effects of anemia on the circulatory system. that how exactly the anemia will affect the circulation. Now let's discuss it. Now, anemia means there are decreased number of RBCs. Now, whenever there are decreased number of RBCs in the blood, it means there is decreased internal friction when the blood is flowing. When we have more RBCs in the blood, then we have more friction between those greater number of RBCs. And when the count of the RBC is low, as in this case of anemia, then there will be decreased internal friction between the flowing blood. Now, as there is decreased friction, this will decrease the viscosity of the blood. Okay? So, and which will become 1.5 times of the water. Now, due to the anemia, due to the less cells, and due to the decreased friction, the viscosity of the blood is decreased. Now, if something has lower viscosity, then it means it is easy to flow. So that means this decreased viscosity will lead to increase in ease of blood flow to the tissues. Now, less cells, less friction, the blood can flow easily to the tissues. And whenever the blood can flow easily to the tissues, it will result into increased cardiac output. Whenever there is increased blood flow to the tissue, there is increased ease of flow of blood, which means increased blood flow to the tissues. For that increased blood flow to the tissues, we need increased cardiac output. That's why anemia is always linked to increased cardiac output. Okay? There's one more mechanism by which the anemia can lead to the increased cardiac output other than the decrease in viscosity, and that is whenever there are decreased in number of RBCs, it means there is decreased oxygen supply to the tissues of flowing blood. So there are decreased number of RBCs. RBCs have hemoglobin, and which carries oxygen to the tissues. When there are decreased in the number of RBCs, it means that less amount of oxygen is now being supplied to the tissues. Now, whenever there is less oxygen supplied to the tissues, it results into the dilation of peripheral blood vessels in those tissues. And whenever the blood vessels are dilated, it results into increased flow of blood to the tissues. And in order to keep the increased flow of blood to the tissues, cardiac output has to increase. So by this mechanism, cardiac output is also increased in anemia. So there are two mechanisms of increase in cardiac output because of the anemia. One is because of the decreased friction, and the second one is because of the vasodilation, because of decreased oxygen supply. Okay? Now, these two mechanisms are increasing the cardiac output in anemia. Now, interesting point is, as we have discussed earlier, that there is decreased oxygen supply to the tissues because of anemia. But you can see the cardiac output is increased. So this decreased and oxygen carrying effect of anemia is counterbalanced by the increased cardiac output. Okay? Now, because of the anemia, the supply of oxygen to the tissues is decreased, but in anemia, there is increased cardiac output. So increased cardiac output counterbalances this decrease in oxygen supply to the tissues. So the oxygen are having a normal supply of oxygen in anemia, but this is at expense of the cardiac output. The heart is using its reserve. Okay, but the problem is when the person exercises, this anemic person exercises, now the cardiac reserve has already been utilized. Now the cardiac output cannot be further increased to such a level to provide the increased demand of oxygen of the exercising muscles. So that's why, and normally the oxygen is being supplied in the right quantity to the tissues, whereas because of the increased cardiac output, but in the case of exercise, that heart cannot cope with the increased demand because heart is already working way more than normal because of the already decreased oxygen supply. So the person feels extremely exhausted and extremely fatigued when the person exercises, when an anemic person exercises, and it might lead to cardiac failure. What is cardiac failure? The cardiac failure is basically that the heart is unable to pump the required amount of blood to the tissues, and the required amount of blood according to the oxygen demand. Okay, so basically the anemic person might go into the cardiac failure. Okay, so this is anemia, the types of the anemia and the effects of anemia on circulatory system. See you in next part.